Very good morning, everyone. Today my paper is on the role of OCT in differentiating between glaucomatous and non-glaucomatous optic neuropathy. There's no conflict of interest or financial disclosure. So glaucomatous optic neuropathy is one of the most prevalent causes of optic nerve atrophy and cupping due to ganglion cell loss or death and retinal nerve fiber layer or RNFL thinning. Non-glaucomatous optic neuropathy presents with optic disc pallor and or cupping, which can sometimes mimic glaucomatous disc changes. So the changes in the optical coherence tomography or OCT measurements in the RNFL layer and the optic nerve head can serve as an invaluable tool in diagnosis and monitoring of the optic neuropathy. The aim here is to study the role of spectral domain or SD-OCT in differentiating between GON and NGON by comparing the mean peripapillary RNFL thickness in the different sectors as well as globally. So a cross-sectional hospital-based study including 55 eyes of 55 patients from November 2023 to April 2024 were taken, out of which 30 were GON patients and 25 were NGON patients. The Heidelberg Spectralis SD-OCT and SPSS statistic software were used for analyzing the results. The exclusion criteria are patients less than 18 years of age, mixed or unclear diagnosis, high refractive error or axial length, any media opacity leading to poor quality of OCT, unreliable HPF testing, secondary glaucoma or any other retinal pathologies like diabetic retinopathy or retinal laser treatment. Now after informed consent and history taking, the best corrected visual acuity of the patients were assessed, followed by color vision, RAPD, intraocular pressure with GAT, slit lamp examination including 90D, indirect ophthalmoscope, 24-2 Humphrey visual field analysis, neuroimaging wherever necessary, and SD-OCT. So the results showed that the mean age distribution in the GON category was higher as compared to the NGON category, that is the 5th to 6th decade, whereas in NGON it was 3rd to 4th decade. And in our study, there were more number of female patients in the GON category and more number of male patients in the NGON category. Now out of all the NGON patients that we took, maximum number belonged to the previous optic neuritis category, followed by compressive optic neuritis, which is your malignancies, and then NAION, traumatic optic neuropathy, and toxic optic neuropathy. As we can see, RAPD and color vision defect were more prevalent in the NGON category of patients, whereas visual field defect was more common with the GON. Now, upon conducting the SD-OCT, we can see that significant peripapillary RNFL thinning was seen in the temporal, that is the inferior, that is temporo-inferior and naso-inferior sectors, followed by the superior quadrant in case of the GON cases, whereas it was more number of RNFL thinning was seen in the temporal, followed by the nasal sectors in the NGON category. Here we can see again the first picture, the glaucomatic optic atrophy. We can see again inferior and superior quadrant thinning, whereas these are the different types of some of the NGON patients where we can see different areas of RNFL thinning depending on the cause. Now this is the fundoscopy images separating the glaucomatous cupping from the different changes that happen in NGON. And the ONH scan again revealed that glaucomatous optic neuropathy showed cupping, whereas NGON showed pallor, cupping or disc edema depending upon the etiopathogenesis. Coming to the discussion, Liu et al. Have described that the best parameters to detect glaucoma using OCT are below normal inferior, superior or global quadrant mean RNFL thickness, and it was also reinforced in our study. Quigley et al. Showed that the pattern of RNFL thinning in glaucoma tends to be greater in the superior and inferior quadrants, while that of NGON varied depending upon the etiology, which was the same finding in our study. When Novel et al. Showed that optic neuritis patients correlated the degree of visual acuity with the axonal loss in OCT RNFL scan, which can be seen before the presentation of visual field, significant visual field defect, which was again seen in our study. So the limitations of this study are that longitudinal study can better help to establish the results of this study, and inclusion of other measurements like macular volume or BMO minimum rim width can be also more conclusive, but RNFL remains the superior criterion. So my take-home message is that OCT can be a novel, non-invasive diagnostic tool along with the clinical findings to differentiate between the NGON and GON category of RNFL thinning, and it can also help to plan our treatment according to this. So these are my references. Thank you everyone for your patient hearing.
A good presentation. In
Thank
your
you.
glaucomatous cases,
Yes.
particularly with the pituitary adenoma. So did you how many of them had like an edema at presentation? How many had atrophy? Even the NAION,
Yes, ma'am.
did you do it in acute phase or did you do it once they had the pallor?
Because it was a cross-sectional study, so I took the scans right on the day that the patients presented. So some of them had presented at the edematous stage and some of them presented when there was already atrophy. So that is why I have
Yeah, I saw the thing.
that is why I have taken different fundus pictures of the different presentations.
Because like if you, in your study, if you had to categorize the RNFL thickness, it
Yes.
depends whether if it is in
Edema or
edema
atrophy.
stage
Yes,
or
ma'am.
in an atrophy stage.
Yes, ma'am.
It would be better if you want to do a study to take all of them in atrophy stage.
Yes.
Then it would be valid to
More uniform.
correlate between glaucomatous atrophy and non-glaucomatous atrophy. Because the moment edema comes into play, it will be thicker RNFL.
Yes.
And in your toxic nutritional amblyopia,
Yes.
which sector was more affected? In your
Um,
toxic, in a toxic nutritional amblyopia, what are the RNFL, like which fibers are more affected?
So ma'am, as
Superior
we,
temporal, medial lateral. What are the
Yes.
fibers which are specifically getting affected?
it's mostly the temporal followed by the nasal fibers which are being affected.
Specific, but what are the like arrangement of your nerve fibers? Okay.
It's the superotemporal and inferotemporal fibers which are getting
You
affected.
get a central scotoma,
output.
right?
Yes,
So
ma'am.
it's usually a papillomacular bundle. So you should usually demonstrate that.
Okay.
Because we are using it for a higher analysis, not just the clinical thing, but you
Yes.
could have done that.
So macular volume measurement would have been a better addition to this, but our OCT did not have those provisions.
Is there any role of repeat OCT in such cases?
Yes, sir. Repeat OCT generally, if had it been a longitudinal scan where we could monitor the patient, the prognosis, and repeat serial OCTs we could have taken, then that helps to establish the thinning, the degree of thinning more. And that is why nowadays we also have built-in serial analyzers in the OCT itself, which will
Yes.
help to maintain the record, and that also establishes this
That's
result.
why I'm
further.
asking, in your case it was done or not?
No, sir, this was a cross-sectional study.
Yes.
So I
that's
mentioned it
very
in my
important.
limitation.
This is the
Yes.
last step.
Yes,
Most of the time, clinically you can diagnose it.
yes,
And madam also mentioned, so depending on the, it may be trauma or it may be due to the other all factor, we can levelize it. But serial examination is the step in such
Yes.
cases. Then only by one study is not, a one
Yes.
time study is not possible.
yes. So that is the
Why?
limitation of my
Why?
study, as I mentioned.
Why?
Yes.
What clues you can in a next follow-up?
Sorry, sir.
Next follow-up, what may be the clue in a non-glucomatous, over the glucomatous? What is that? What will be the difference you can think for in future? Suppose today you done one set. So one best is that is not possible to rule out all. So in seconds
Yes.
after you 2 months, 3 months, if you go ahead, then what will be your outcome? Can you tell me something?
So,
In glucomatous, what will be and in non-glucomatous, what may be the
so
finding?
in glaucomatous, there is progressive RNFL thinning
Yes,
and
yes,
something which is called as secondary degeneration. So that once even the IOP has been lowered also,
Is
but the
impossible.
adjacent
In
cell-
glucomatous, improvement is impossible.
impossible. It
But
is
in
irreversible.
non-glucomatous, there may be a
Maybe
possibility. It may
improvement.
not.
Yes.
That's